Hi, and welcome to Cases from the Coop, an educational ultrasound podcast short from Cooper University Hospital's Emergency Ultrasound Division. My name is Subxiphoid, and I am the Emergency Ultrasound Fellow. So, for my first case, I figured we'd talk about one of the most cherished uses of emergency ultrasound, at least for me. When the 65-year-old patient comes in via medics, and the paramedics tell you that he's got a history of CHF, COPD, emphysema, and fibromyalgia, and that he's just been more and more short of breath. They tell you, doc, I listened to his lungs, it sounds like he's got some wheezes there, so we put him on a bunch of DeoNebs and some CPAP, and we brought him in, and he looks a little bit better. I could listen, and I usually do, but my sensitivity of that's about 60%. Or I could grab the ultrasound machine, put the probe on his chest, and take a look. And that's usually the way I practice, because it helps clarify this so quickly. So let's get started. You put the probe on the patient's chest, you start looking, and you slide it down from the left lateral side, just lateral to the sternum, and you slide it straight down the chest. We'll get into orientation another day, because that's a whole debate in and of itself. And you get this view. This is called the parasternal long view. So we're using the phased array probe, as you can see from the triangular footprint. That's chest wall right there. That's the right ventricle, the most superficial structure, and therefore the most likely to be stabbed if you have a board question about that. Here's your left ventricle. Here's your aortic outflow tract. Here's your aortic valve, and here is your mitral valve and your left atrium. You can see the pericardium back here, and just a hint of the descending thoracic aorta. So, if looking at this image, I can tell you that it looks like the mitral valve is contracting. It's not contracting the best because it's not that close to the septum. If you were to put M mode over it, you could look and see and quantify that as E-point septal separation of greater than 7 millimeters, suggests a depressed ejection fraction. Also, as you look here, it looks like the walls aren't coming together the best. Now, when we switch orientations by rotating this 90 degrees, you'll get the parasternal short axis. So again, here you see the left ventricle. Now, this is a lovely view to get a very good idea of ejection fraction, and it's the way cardiology will frequently look at it and decide. So as you can see here, you have the septal wall, your right ventricle's up here in this area, you have your inferior wall, and your free wall right there. And you can see the papillary muscles. Now you could cut the short axis any direction from the mitral annulus all the way down to the apex of the heart. As we're doing it here, you can see that the papillary muscles, which is the best spot to get a good estimate of ejection fraction. And as you can tell, just looking at it, it's not squeezing well. It's barely doing anything, which would suggest a severely depressed ejection fraction. Remember, in point-of-care ultrasound, we simply break it down into normal, hyperdynamic, depressed, or horribly depressed. And this is quite depressed. Now, as you move down from there, you move into the apical view. So for the apical view, you can slide over in the parasternal long axis orientation, and just slide until you get to the apex of the heart, and walk it out, and then you can get this glimpse back here. Now, for this glimpse, for this particular view, the thing to remember is that as you're looking at the apical forechamber, you want to make sure that you have both of your valves in view. This is your mitral and your tricuspid valves, and if you can see both of those valves, that would suggest that you're in plane. Now, this is the apex of the heart, this is the base of the heart. You can see the left ventricle, the right ventricle, and both atria. This is a really good view to help you figure out whether or not your ejection fraction is depressed, and that helps you clarify this significantly. So moving on, you slide the probe down further in the chest, and you go to the subxiphoid view. The subxiphoid view, you literally slip right under the xiphoid process, pointing up towards the left shoulder. You'll see right here you have that RV again, demonstrating that it's the most superficial structure, your right atrium, your left atrium, and your left ventricle. This is a great view to tell you overall pictures of it, make sure there's no large circumferential effusion, and it's a view we're all quite familiar with from the FOST exam and from cardiac arrest patients. Now, once you're done with that, you pop the probe onto the chest, and you hold it in the curvilinear probe with orientation with the marker pointing straight up, and you slide it down the anterior chest, and you look for rib shadowing, which you can see right up here. You can see this hyperechoic or bright white pleural line, and then you can see these search-like patterns that are coming down all the way from the pleural line and extend as far as you can see. Those would suggest B-lines. Now, B-lines are highly suggestive of a pulmonary interstitial fluid process, and in the setting of seeing a reduced ejection fraction, that's highly sensitive and specific for acute pulmonary edema and likely cardiogenic pulmonary edema. So, for this particular case, the patient gets put on a CPAP, gets put on a nitro drip, gets a more nuanced approach to figure out whether they're volume over or volume under. They were volume over, so they're given diuretics eventually. and after a couple of hours of being on nitro and CPAP, they came off the CPAP and were able to go to the medical floor to get better medically managed before they went home. And folks, that's about it from us for this case. Feel free to get in touch with us using our Twitter handle @CooperEMUS. We are happy to always hear your cases, comments, questions, and concerns at any time. Feel free to give us some feedback and share with your friends if you found this useful. Thanks, and talk to you soon.